Welcome to my presentation today. My name is Michelle Fole and I'm a speech and language therapist working at the National Centre for Electronic Assistive Technology Service in Wales. Our service covers all of Wales on a lifetime basis, providing assessment, supply and support of power-based environmental controls and communication aid equipment to NHS patients. My specific role is working as a senior speech and language therapist with children across South Wales who've been referred to us specifically for assessment for a power-based communication aid. And the topic that I want to talk about today is how the recent challenges created by the pandemic have led to a really positive change for my service delivery that's been able to place my patients and their families right at the heart of the process. As a direct result of the pandemic, as with everybody else, my service delivery had to go from being always face-to-face to being virtual in what felt like an almost overnight change. I was really concerned as to how this was going to impact upon my patients. There's a strong evidence base available, along with my own anecdotal experience, that shows that families can find it hard to integrate equipment into their home lives at the best of times. They generally have an established communication system that has worked, and the equipment can sometimes feel as though it's an additional layer of complexity in an already challenging process. My concern was that even more barriers may be created by the kit arriving at home with no one immediately available to discuss or support it with the family. However, it had to happen. So, with lots of planning, anxiety, and the willingness of a lovely family to be my guinea pigs, I got to work. The device was couriered out to home and a virtual appointment arranged for a day or two later. Just to lend some context, I'll briefly run through how the appointments used to work prior to COVID. So all appointments were face-to-face within the patient's locality, generally at the child's school. I would be there, the local speech and language therapist would also be there, the class teacher, a learning support assistant could sometimes be part of the session, and also maybe a special educational needs coordinator as well, and obviously the parent. And what I found was that even with the best will in the world, the family could end up being a little on the back foot in that room. They'd be a bit reluctant to kind of put themselves out there and try using the kit in front of all those professionals. And I'd get comments like, yeah, this is great, but you concentrate on supporting the school staff and we'll look at it later. So then the device would then go to class with the child, rightly so, and the family wouldn't necessarily see it until after school. And then day-to-day life happens, things get busy, the momentum from the training would be lost, and the family would find it really hard to get going. The device tended to get put to one side and just not used in the home environment. So my first virtual session, I really think I tried to sort of overcompensate for not physically being in the room. I had lots of screenshots of the device with arrows pointing at areas that I was referencing to. I had YouTube videos lined up to demonstrate different strategies. But before I even drew breath to start the presentation, the dad jumped in and said, yeah, that's great, Shell, that's great. And we'll get onto that in a second. But first, can you tell me how to get the device to do this? I can't remember what he asked now, but it was something detailed and technical, and showed to me really quickly that he had a clear knowledge around the equipment and half my presentation wasn't going to be needed. And actually, from that point onwards, the stage was set. Every subsequent appointment started in the same way. Parents were coming to my video appointments asking questions that they had already prepared. They were wanting to know how to do specific things. They were ready to have conversations around how to start incorporating the equipment into their lives, and they wanted to discuss and explain what they had found difficult so far. One parent during one session actually likened receiving the equipment by courier as though she felt like she was in one of those YouTube unboxing videos that children watch. And for me, that was my light bulb moment. Turns out that having the kit first, opening the box and playing around with it in your own home with no room of professionals looking on was actually a game changer for the families and really helped to put them in the driving seat. Words that kept coming back to me as I was reflecting on my sessions were ones like empowered. Families were taking control of the sessions. They were coming to my appointments with an agenda and taking control of what they needed to find out. They had ownership of that equipment from the minute they took it out of the box, and that was helping them to feel really engaged in involving it in their child's life. It has been and continues to be a really amazing journey to see this change happen. It's had such a positive impact on the uptake of the equipment and its longevity of use. So what next? I've been sending out patient surveys to get some qualitative feedback, and happily the comments that are coming back are reinforcing my perceptions, which is obviously a good thing. I've had the opportunity to work with Tech Cymru, which has been great. They have done a more detailed review of my patient journeys before and during COVID. And although not yet completed, the feedback that we're getting back is really exciting and showing some proper significant benefits around keeping this change going. And to that end, really, the equipment is going out first still. So I'm finding even greater benefits with my appointments that are now happening face to face. So families are coming to these multidisciplinary sessions and it feels like they're ahead of the game and they're ready to discuss straight away. They're actually taking part, not just taking part, they're leading sessions more, and they're becoming more involved in the training of school staff, which is really reinforcing the value of the equipment to schools and placing a greater emphasis on the importance of the school working with it in the same way that the family is, which is obviously just brilliant. So I think to conclude, this has resulted in a really positive change. Something that started out being forced upon me has become a really positive experience that's put my patients at the heart of the process and has helped them to take absolute control of the sessions and the equipment for the child. So I just wanted to end with some comments taken from my recent patient surveys that underscores my conclusions, happily, and as far as I'm concerned, are really the best advocate for change that I could possibly ask for. Thank you so much for attending my session today. I hope you found it useful. I've included a reference here that I referred to during the session, and also my email address. So if anyone wants to talk to me in any more detail about any of this, I'd be more than happy to have that contact. Thank you.
Mae'n bleser cael cyflwyno heddiw. It's a pleasure to be able to present our talk for you today, which is on the rapid development of a traumatic stress service or a trauma pathway within the employee wellbeing service at Apnoea in Bevan. My name is Dr. Helen Penny, and this is part of the work that I did along with Dr. Jerry Serrell and Dr. Rachel Vaughan, who's also going to be presenting today.
So the Employee Wellbeing Service in an R in Bevan, one of the things we provide is a psychological therapy service. In September last year, it was expanded to include clinical psychologists. Up until that point, we had a team of really experienced counsellors, and it was recognised that it would be helpful to also have clinical psychologists to work alongside them. We also provide other interventions and support to the wider system, helping teams and different departments and things like that. We're based in Fetchra Grange, but we do some of our therapy work out of some of the other sites within the organisation. So the rationale for developing the trauma pathway came from the recognition that during the pandemic, healthcare staff in particular were experiencing high levels of stress and also being exposed to situations and things that were over a prolonged period of time, particularly that could cause them some distress. And so the trauma pathway then was set up in order to meet the demand of staff experiencing difficulties of that nature. So we were particularly interested, obviously, in people with trauma responses, which typically is referred to as post-traumatic stress disorder. We recognise that people could be experiencing high levels of distress, but also it could be impacting their ability to come to work. So that's really why the trauma pathway was put into place, to meet that anticipated demand.
And so with regard to the trauma pathway, we were really keen and had this kind of really strong sense of a duty of care for our staff as well, who are experiencing these traumas at the workplace. And we really wanted to be able to ensure that our service mapped onto best practice and national standards. So we made sure that our service mapped onto Traumatic Stress Wales's Quality Improvement Initiative. And in that, we provided clinical assessments and use standardised outcome measures in order to be able to monitor people's symptoms. We delivered evidence-based psychological interventions, and in particular cognitive therapy for PTSD and EMDR. We wanted to ensure that we could provide at least 8 to 12 90-minute sessions, so people were actually getting an appropriate dose of therapy. And the service was face-to-face, although we did also have some online sessions when needed to ensure that it was a smooth flow of therapy. And we also, in the beginning, when there was no vaccines, used a walk and talk service. So we were outside walking whilst doing some of this work with our clients. And these were delivered by clinical psychologists. So between September and August, we saw a 300% increase in referrals to the Employee Wellbeing Service overall. And the vast majority of those referrals were seen by our counsellors providing excellent supportive psychotherapy. 40 people were referred to the trauma pathway within that time frame, and 30 of those people had clinically significant levels of PTSD symptoms. By the time we conducted the audit, 14 people had completed treatment. Nobody had dropped out, and all of those people who had completed treatment by that point had achieved recovery.
So in terms of outcomes, as Helen was saying, we had some good outcomes of the people that had completed the pathway at that point in time when we looked at the data. People were demonstrating a good reduction, clinically significant reduction in PTSD symptoms. There were no adverse outcomes reported, so even though we were doing trauma reprocessing work, which could be quite difficult for clients, overall that they responded well to that with no difficulties emerging from that. And our qualitative feedback was generally really positive and affirming.
So of course, given that we developed this service really quickly in the middle of a pandemic, we've learned a lot in the process. And I think one of the lessons that was important to identify was the type of traumas that we were working with. We have seen a lot of people who have developed PTSD as a consequence of working on the COVID wards on the front line during the pandemic, but we've also identified lots of other traumas and they were reported, included childhood trauma and workplace assaults. The findings also support the efficacy of a trauma pathway within an employee wellbeing service in alleviating PTSD. And this is really important, particularly in line with Traumatic Stress Wales's national strategy about being able to offer an intervention where people first present. So rather than referring on and people being put on waiting lists, we were really able to support our staff quite quickly. And also, interestingly, preliminary evidence really indicates that the existent evidence-based psychological interventions are absolutely appropriate and map on very well to pandemic-induced PTSD. So the Allers and Clark model, which we use for cognitive therapy, was definitely appropriate in terms of applying it to people who'd experienced PTSD as a consequence of working on the front line during the pandemic.
So in terms of moving forward, we've learned lots about how to put in place a trauma pathway, and one of the key things that we've been looking at now is some training and supervision and rolling that out within our wider team with the counsellors in our team so that they also can provide this evidence-based trauma focused therapy. And so our main aim in doing that is that then that there's not the passing of clients over to a psychologist if a counsellor then has started working with someone experiencing trauma. And then as a result of the pathway too, we identified that there's also people that need higher intensity work than we had been currently offering that are PTSD related presentations. And so that's the steps we're taking moving forward.
Diolch o galon, thank you very much. We hope you enjoyed our presentation.
So rehabilitation is critical to ensuring our population's recovery from the impacts of the pandemic and the long-term sustainability of the health and social care system, with allied health professionals, or AHPs, at the centre in shaping the rehab agenda. In response to the pandemic, an All Wales multi-sector rehab task and finish group developed a rehabilitation framework, underpinning guidance, evaluation framework and modelling resource to support services to evidence the benefit and outcomes from investing in rehabilitation, and to help identify and understand the predicted increased demand for these services as a result of the adverse effects of the pandemic. Notably, a key challenge is the required capacity for AHP services to meet this increasing demand. Therefore, consistent national data on AHP services is crucial to understand capacity and demand and inform this modelling work. Quality data or good information plays a vital role in improving the quality and safety of services we provide, better decision making, as well as being able to identify trends and patterns, draw comparisons, predict future events and outcomes, and evaluate services, enabling us to understand demand and allowing us to make informed decisions regarding optimal utilisation of our skill set and workforce deployment, significantly improving our ability to respond to increasing needs. Recognising the need for consistent national AHP data, a proposal was put forward for the development of a minimum data set and reporting requirement for rehabilitation services. Supported by Digital Health and Care Wales, the Executive Directors of Therapies and Health Sciences, the All Wales Heads of Adult Services Group from all local authorities, and the Strategic Programme for Primary Care. The intention being that this data would be extracted and collated on a national basis to raise understanding of the range and contribution of AHP's work in health and social care, drive and ensure the rehab agenda remains a key and ongoing priority to all levels in the immediate and long-term needs, and enabling us to utilise data generated as a tool to identify the required staff resource, inform wider impact of potential absence of rehab, as well as improve practice. All of which aligns with the transformation agenda for a healthier Wales, the Allied Health Professions Framework for Wales, and the Primary Care Model for Wales.
We're really pleased to be part of this pilot project to collect COVID rehab data. So how did we collect the data? Well, we utilised the 4 population groups from the All Wales Rehabilitation Framework. The first group included people who were recovering from COVID. The second group included people who were awaiting paused planned care. The third group included people who avoided accessing health services who are now at greater risk of disability and ill health. The fourth group included people who were socially isolating or shielding. In addition, we added a 5th group for patients who had rehabilitation needs but had no effects from the COVID pandemic. Our information team in Powys identified the most effective method of collecting the rehab data codes on our existing IT systems. All AHP teams were invited to participate in the data collection. However, we had most engagement from the physiotherapy and occupational therapy teams. This is most likely due to the short timescale for implementation and the fact that data was not a mandatory field. In practice, the first therapy clinician that assessed and saw that patient identified the appropriate rehab code and inputted that onto the system. This way we were able to record data for unique patients and prevented any duplication.
For this full date range, we can see that Newtown had the highest rate of rehab contacts with 20% of the overall Powys rate. We can also see the rate of those who were referred to by a physiotherapist, occupational therapist, how they've had their consultation method, whether they're open or closed since between these two dates, whether they've had effect from COVID-19 or not, and the sub-effects if they are affected by COVID-19. So we can see here, if we focus on Newtown locality, that they've actually had a higher rate of occupational therapists than the Powys average, with 46%. And we can also see that their virtual patient video contacts are much higher than the Powys average, with 18%, as well as their phone contacts. If we have a look at the next locality down, which is Welshpool and Montgomery, we can see that they in turn have a higher rate of face-to-face contacts and a lower rate of those phone and videos. We can also focus on those who've been affected from COVID-19 with their referrals. And we can see that the Brecon locality has a higher rate of those who have been affected by COVID-19.
Following doing the project, I think the most exciting thing for me was to see the data that the clinical staff on the front line had put into the system, and it was able to be showed on a map of Powys, giving us that local knowledge of what the service users had received from the AHPs in Powys and where. So the conversation around the different towns and the populations and the demographics on how many people had used virtual consultations and how many people had been affected by COVID. So I think this small project, be it small in number, just demonstrated the power of information and the opportunities such data could help us with service design and workforce redesign. So for me, this project, be it difficult to sometimes get that frontline staff engagement, was an opportunity for us to show to the frontline staff that data you put in can help us design and transform services in the future. So for me, that's really what this the power of business intelligence could offer us as service leads.
Data is a really important tool to help us describe the activity and outcomes from all of the work that allied health professionals are doing. We have a huge lack of transparent, usable, once for Wales data that will allow us to benchmark and articulate what we're doing. Having this standardised data is going to allow that clear understanding of how we are making a difference to the people of Wales. It helps us to put this into the context of the value of our healthcare interventions in terms of improved outcomes for people, better experience for them, being able to demonstrate good use of the resources, but finally also to help you understand the difference that your intervention is making or where we might need to change things to make sure that they do. Thank you. I think this is a really exciting way forward for us in the future.
Hello, my name is Rianne Jenkins, and together with my colleague Robert Goldsmith, we work as physiotherapists at Cardiff on the Vale Health Board. We're going to present the work we've done to develop a new pathway for acute radicular pain. Radicular pain is pain felt in the arm or leg coming from nerves in the spine. Sciatica is the most common term used, and this describes pain felt in the leg from the sciatic nerve.
We reflected on the existing pathway. Through qualitative research, we heard patient stories, developed a new multidisciplinary pathway, evaluated our data, and we're sharing our outcomes with others. And now we're looking forward to areas where we could improve.
Although many people with sciatica improve with physiotherapy, we noticed that people with acute sciatica who had high levels of pain struggled to do physiotherapy exercises. Spinal injections help, but are best used in the acute phase. The problem was it took a long time, from GP to physio 6 weeks. Patients couldn't manage physio due to severe pain and were referred to an interface service, waiting another 6 weeks. Further 3 to 6 months for an MRI, 3 to 6 weeks for a review of the scan, and then injections were all classified as routine and could take up to 2 years. By the time patients were reviewed following spinal injections, the process would have taken 2 to 3 years. By this time, they had a prolonged period of severe pain. It may have resolved or become chronic and harder to treat. We wanted to speed up the pathway in order to improve outcomes, reduce the length of time patients were struggling, and help patients engage in rehabilitation more easily.
Acute radicular pain can be very distressing. The average age of our patients is between 30 and 50 years old. They're often working and raising a family. We recognise the high level of pain and distress expressed by the individuals we were seeing in clinical practice, and how hard this made rehabilitation. We wanted to understand this in more detail. The patient stories here capture the distress of living with severe sciatica pain. Our qualitative research in 2019 interviewed 13 patients to understand the experience of sciatica. The resulting publication gained a lot of attention and won an award as the most read article in that journal that year. The thematic analysis identified 3 themes relating to the illness experience: severe, unpredictable pain that was mentally and physically draining, and a feeling that the pain was not visible and therefore underappreciated. Individualised rehabilitation was seen as important, as some participants couldn't stand and some couldn't sit. Participants wanted a clear plan for support. Together with other published work, this told us that patients wanted quicker access to pain relief and information, shared decisions, individualised management, and clearer collaboration between services. There's a need to identify those patients who might benefit from injection or surgery.
So we built a team. We sought out agreement from key stakeholders in radiology, Dr. Kath Lyons, and orthopaedics, Mr. Stuart James, to form more integrated ways of referring for MRI scans and injections. We were able to obtain agreement for a fast-track imaging, and Dr. Lyons agreed to hold injection slots in the operating theatre list for the new pathway. We set up a new rapid access face-to-face clinic in physiotherapy for patients to be assessed by a specialist physiotherapist. We later recognised one of the major barriers to the speed of the pathway was the referral process and booking system from primary care. Working with Emma Perkins and physiotherapy first contact practitioners based in GP practices, we changed the booking process, enabling rapid referral for a face-to-face assessment. The new pathway. Patients with severe pain for more than 6 weeks, not responding to conservative care, could be identified early by the first contact practitioner, and a fast-track MRI within 2 weeks of the referral could be requested. This was in order to inform if a spinal injection was an option. We created a new pathway and named it as the acute radicular pathway, which was known across the services. Spinal injections were fast-tracked to within 2 weeks. We developed guidance for physiotherapists working in rehabilitation and collected patient-reported outcomes on pain and disability. Patients stayed in physiotherapy throughout the pathway, integrating spinal injection and rehabilitation. Those who didn't improve and needed a surgical opinion could be discussed by the team and listed for the virtual multidisciplinary team meeting. From the onset of pain to post-injection review, the time now is between 12 to 16 weeks. This time frame is in line with optimal time for patients to consider surgical intervention.
So far, 105 patients have accessed the new service. We've recorded pain rating scores, disability levels, and the time taken for each part of the pathway. Prior to the injection, the average pain rating was 9 out of 10, and an 18 out of 24 level of disability on the Rowland-Morris disability scale, where higher scores are worse. Appropriate patients can now access an MRI within 2 weeks of referral and receive their injection within 2 weeks of referral. This is compared to a waiting time of over 2 years previously. The average pain score after injection is 3 out of 10, resulting in a 66% improvement in pain. The level of disability improves from 19 out of 24 prior to the injection to 10 out of 24 after the injection, resulting in a fantastic 44% improvement in function. By way of benchmarking, a pain change score of 2 points on a 10-point scale and a percent change score of 33% were best associated with the concept of being much better. And there is a consensus that 30% improvement in function represents a worthwhile benefit to patients. The injection allows patients to continue to work on reducing this disability further by providing adequate pain relief to engage in physiotherapy. Only 8 patients have chosen to be listed for surgery. And finally, we'd like to finish with a patient story of her own journey through the pathway. Thanks for listening.
So I started to notice low back pain and muscle spasms initially last August, which I'd never had before. I'd started running during lockdown like many others, and I believe I'd overtrained. I was getting electric shocks down one leg, which progressed over the next 8 weeks, so I couldn't sit down, drive, or lean over to dress my children, who were aged 1 and 3 at the time. Working was keeping me really distracted, so I didn't take any time off, but I did have to lie on the floor whenever I could. I was taking naproxen, paracetamol, and codeine every day, but I couldn't tolerate the drowsiness the amitriptyline gave me. I had an MRI arranged urgently by my GP when I started limping, and I developed a weakness in one of my legs. I was rung by radiology and booked in later that month, which was very efficient. I had a follow-up 4 weeks later with an advanced physiotherapist. I was worried during the time lapse as one of the discs was completely extruded and the nerves were being squashed. During this wait, I consulted with a private surgeon who reassured me I didn't need surgery and I could try a steroid injection. This consultation was reassuring, but it focused mainly on my MRI and my treatment. During my advanced physio appointment, which was done virtually, they assessed not only my pain, but my function. They linked my sleep, mood, appetite all together, and I realised all these things had been affected in a way I hadn't appreciated. Within 48 hours, I had a spinal injection at UHW organised. 48 hours after this injection, I needed no pain relief at all and was able to sit down to watch TV again for the first time in 3 months. I'm at the 12-month mark now. I've just completed a mini ultra marathon. I do still get some low back pain with numbness in the side of my foot. It comes and goes, but I appreciate that these symptoms might be transient until the disc resorbs. I'm full of gratitude to the team for getting me sorted as quickly as they did and getting me back to living life again.